Everybody, we're going to now go on to item 2.4, which is the care home preparedness, and I'm handing over to Jill.
Thank you, and I do appreciate that this is a long paper with a lot of attachments. I don't intend to go through all of that, but what I would like to do is just to set some context as to how we got to this position, and really just to give board members some information really as to where we are with care homes currently in terms of COVID and the outbreaks that we are seeing. I do think that within this health board and across our region, we've got a very strong foundation in working with our partners across health and social care and with our care homes. And at the very early stage of the outbreak, we were working with care homes around their business continuity plans. And board members will be aware that the testing regime that was in place at that time, and certainly we were well ahead as Hywel Dda, was just testing symptomatic staff and individual patients, and doing that as and when we'd opened up our testing system to allow that to come into the system, probably, as I say, not necessarily across the whole of Wales, but we were doing that and identifying isolated cases. However, when we had our first large outbreak in a Llanelli home, we really realised at that point that it happened very, very quickly. And it was quite difficult for all of our services to come together and respond to the impact that had, both in terms of staffing, but also managing patients in that kind of environment, which is not set up in a ward situation. And also ensuring that primary care was providing the appropriate input as well as that at that time. And that led us to the development of this escalation tool that you can see in front of you today, which looks at a whole range of factors that would cause us to be concerned around sustainability and viability of an individual home, but also the sector during this period. But I think what we put in place at that time, certainly in terms of individual care homes, has been extraordinary. We have supported with a lot of training with our infection control teams. We supported initially with PPE when stocks were not coming through the route that care homes can normally access, which has been provided through shared services directly into our care homes, not through the NHS, but we did support on that. We were helping them with their red and green areas. We set up some psychological support for care home staff, and we set up some virtual meetings with our care homes so that they could share their experiences. And importantly, we worked with our clusters and secondary care colleagues to make sure that access was appropriate. And that, as I say, led to this particular escalation tool. Now, we've got, it says in my paper that there are 122 facilities. That is for adult homes across our system for nursing and residential. But when I come on to mass testing, we're actually having to test in 185 facilities, which includes mental health and LD. So potentially 4,000 individuals and all of their staff is part of now what is a mass testing process. For in terms of the outbreak, we have seen an outbreak in 4 care homes in Pembrokeshire, 7 care homes in Carmarthenshire, and to date none in Ceredigion, although they have had a positive case. And I think one of the things that has been particularly important is making sure that, as I say, the access to care and support is important and appropriate at that time. And the Chief Executive of Care Inspectorate Wales, Julian Baranski, has written to the head of every safeguarding board in Wales, raising her concerns really around the rights of individuals within care homes and ensuring that they have both access to primary care and appropriate admission to secondary care where that is appropriate. And if I can give you the sort of scale of the order of what we're seeing in an outbreak, in one of our 55 bedded care homes within Carmarthen, they have had 18 deaths. So out of a 55 bedded home, that is significant, not only for the residents and their families, but also for the ongoing viability of the business, which can't admit new cases, new residents at that point in time, but also the psychological impact on the staff there. Seeing that number of deaths at this time and ensuring that they have got systems in place to try to prevent the ongoing outbreak. As I say, we're now moving into that period of mass testing. We had already stepped up in Hywel Dda outside again of or ahead of Welsh Government guidance, but we now have a mass testing programme in place to test both asymptomatic and symptomatic individuals within every care home. So that is 185 facilities. And if you can think about, as Steve alluded to at the beginning, the impact on our teams from our infection control team and long-term care team in particular is extraordinary. We do have help from the Army, but testing in 8 care homes a day. The Army can support us with setting up tents in 4, but doing all the swabbing and then going back on a regular basis for a period of 28 days, retesting individuals. And if you get a new negative, a new positive case during that period, the clock starts again. So this is a long-term plan, although we have to have every single care home tested. Well, the government wanted to initially by the 1st of June, but that just really wasn't practical. And as I say, we were ahead of the game. So it wasn't practical on any scale, but we expect to have achieved that within the next 3 weeks. But I do think that there is going to be some scrutiny on this, and I'm comfortable that we review this on a regular basis and with our health and social care partners weekly. But within each county as well, we've got an oversight group so that there is ready support and review, and we're looking at the impact on businesses, not only, as I say, in terms of COVID, but also in terms of viability for the future. And we have to think about going forward what or how the sector is going to be very different. We had already started as part of our strategy within Halgar to look at that future model, and I think it's timely then, as we come out of this, that we go back into that phase of looking at transformation and where we see the role that the sector plays going forward in our overall business. And who think we've got 3,000 to 4,000 individuals within our care homes across Halgar. That's an extraordinarily large amount of our population. And we have to think about the type of model going forward in terms of our work, both the statutory organisations, but also with the independent private sector. So as I say, we've brought this escalation tool in place. It has been recognised now across Wales as something that other health boards can adopt and other health and social care systems. It's something that I believe is standing us in good stead, but we're working very closely with our partners, with our operational teams in terms of trying to address what's a really important part of our system, and we know is going to be scrutinised both now and retrospectively as we move forward.
Questions? Judith?
Thank you, Chair. I think this was a really good report, and actually don't apologise for all the detail, because I think it's very helpful to see all this from an independent member point of view, because we know that we commission so many facilities and beds in this sector, in fact more than the hospital. So I think it was good. I think you've probably undersold that actually the escalation policy has now been, again, another exemplar and has been rolled out to all the health boards. So I think we should note that. My question really related to Jill's last point about the future, and I think this will be a real discussion point within the transformation group. But I wonder if Jill's got a feel for timescales about actually having those discussions with our partners about the model going forward, and actually how we might use the transformation monies to support that.
In many ways, it's starting now, Judith, and as I say, it had started before COVID. I think this sheds a different position, and as I say, the real issue will be, I think, what we want to commission. So often we get what we've always got in these situations, and I think we have to act as commissioners, really, in terms of trying to look further afield, see what's out there, and think again probably whether or not there is more that we need to bring within our own system, and perhaps rely less on independent sector businesses. That's not, in this context, please don't misunderstand me, to signal that we are going to stop commissioning from the independent sector. We're not. I mean, we could never absorb 3,000 individuals within our system at the moment. But this position alone, I know that a number of care homes have called in the local authority to look at their accounts. Welsh Government have provided an urgent payment, 52 million across Wales, to support care homes where there is some financial difficulty, and also in terms of their costs in meeting COVID. But I think it really does allow us to think differently around the type of system we want for people that we're caring for. And I do have to say that some of the facilities that individuals are in at the moment aren't conducive to the type of care we want to see in the 21st century. And I suppose in some ways, we were talking about the model around Connected Wellness Village. There was going to be a new care village within that sort of context. So we want to see something that's not just for older age, but also will have a range of facilities as people's needs change from being quite low level to quite dependent, in a range of facilities within that sort of village approach. So I would say it's work, Judith, that we'd started before COVID and we're continuing. We do meet with care home providers as well, and we've got some provider groups that were set up to engage with us prior to COVID, and we want to continue to step that up as we move forward.
Thank you, Jill, and thank you to your teams for all the tremendous work they've been doing working with this sector.
Thank you. I'm going to bring in Michael and then Simon.
I'm not sure, I was signalling.
All right. That's fine. Simon and then John.
Thanks, Chair. I just wanted to say I thought this was an exceptional paper. I congratulate Jill on its sort of depths and richness, and it's so comprehensive. I've heard anecdotally that during the crisis there's been greater cooperation between the sectors and between individual care homes, and because people who work in care are rightly key workers, it's reminded people of the importance of that occupation, and that there's been an increase in interest from people who want to work in the care sector. I don't know whether those are things that Jill has actually come across as well.
Yeah, we have, even with some of the people who are volunteering, you know, sometimes perhaps it's been a bit of a Cinderella service in terms of people's perception really of care, but those who I've talked to when I've gone out have said how privileged they felt to be working in that sector, and I hope that it has driven a renewed interest even amongst younger people. And when you go into our care homes, you will see actually a high level of younger carers, and that's good and bad, because at this point in time the level of psychological support that can be needed in terms of some of our younger carers seeing and experiencing a high number of deaths, for example, in care homes is something that we need to support. But also in terms of care homes working together, we've tried to encourage them, a bit like clusters of GP practices, for example, that can still maintain their independence, but can look at how they can share some of the services between them, and that needs to be part of transformation as well. What backroom services or support can people have from working together? And one thing that, as I say, we did do, and we will do more of, we organised a Skype or Microsoft Teams, I can't remember which one it was, meeting with all of our care homes for those who wanted to join. And there was overwhelming positive support, and what people were able to do was to share their experiences of the pandemic and how they've coped with it. So where some care homes were just beginning to experience an outbreak, they were able to learn from others how they've managed, and care homes are coming together in a very different way virtually. So yes, Simon, I think there is renewed support out there for the sector and for what they're doing, a renewed interest in terms of the opportunity, and that's as well for businesses to work together as well.
I'm going to bring in John and then Paul.
Thank you, Chair. Can I just make a general comment, Chair? One of the things that we've always had a challenge with as a health board is community infections outside of COVID and how that impacts on our services. And I just want to say to Jill and to Mandy how the integrated preventative guidance that's been developed at the end, one of the appendix, is commendable. It's a thorough document. It demonstrates integration, and it demonstrates how local authorities and us are working to manage often infections within the community that then impact within the within our health board and our secondary services. So I was very pleased to see it.
Thank you, John. Paul?
Thank you, Chair. In the S-bar on top of page 4, Jill, you highlight how the escalation policy and processes could be utilised to deliver other social care services, such as domiciliary care. Can you clarify whether within the definition of domiciliary care you're including personal assistance? and also what the position would be with for the support that could be provided to unpaid carers.
Sorry, did you say personal assistance?
Yes.
I'm not, yeah, thanks. I'm not necessarily sure I understand what you mean, but I think from domiciliary care, I mean support packages of care going into people's homes. So it would be about personal assistance in that context, unless I'm misunderstanding you, Paul.
It could be people who are working with people with learning disabilities in the community, perhaps.
Yeah, yes, it's extended in all of those sorts of situations. So yes, I would say yes, very much so.
Thank you. And the position with regard to unpaid carers?
In terms of unpaid carers, yeah, Sarah?
No, you can carry on if you want, but we've also extended it to all unpaid carers as well, feeling that they're important. But I don't know if you want to say, Jill, they can call the command centre and enter that process, which again I think is a first across Wales, because you know we know we have that 49,000 carer group, so without them we would have been in an unmanageable, overwhelmed situation. So I think that's again something the board can be proud of, is that we early on made that decision and moved to include them in that command centre process.
Thanks very much. That's great. Thank you.
Thank you, everyone. Thank you, Jill and Mandy and all the teams. I think, well, your report has shown that from very early on, as Sarah said, we focused on doing the right thing as a health board. It's excellent to see. As a board, we'd like to see the vision and new models moving forward. How we're strategically going to reach a better place in the context of all the challenges, but it's a wonderful caring and an exceptional piece of work. So thank you. Next item on the agenda is the calculating and maintaining the staffing levels during COVID-19. Mandy.
Thank you. I felt that it was important that we had two papers here today. One which is the assurance report, which comes later on in the agenda, which is a statutory requirement for us to receive annually. But I wanted to take the opportunity to just provide assurance to the board about the extensive amount of work that has been undertaken in relation to nurse staffing in response to COVID-19. And I think what you will hopefully see from the paper is that we have considered all areas across the organisation, 25A, 25B wards, the COVID repurposed wards, because obviously there are no statutory or guidance even that we've received in terms of how you calculate for a repurposed COVID-19 ward. So we've had to do some work on that using the basis of the Nurse Staffing Act to help guide us on that journey. We've also looked at the critical care units and used the national guidance, the expert guidance on how we would go about staffing critical care units should we need to extend and maximise the number of beds that we would be required to operate if the peak had been realised in terms of the modelling. Likewise, the field hospitals, although we haven't yet commissioned the field, utilised the field hospitals, work has been undertaken in terms of calculating staffing levels, based again against the patient profile. So depending upon the needs of the patient, throughout all of our calculations, we have considered the needs of the patient to be the primary focus and driver around which we calculate the levels. Likewise, community nursing services and mental health services, together with, as we heard earlier in the previous paper, paediatrics. The one area where we have lifted some of the establishments has been in older people mental health services, and that is in response to the needs associated with management of personal protective equipment. And I think that's just important to emphasise that where we have seen a specific need, we have actually responded to it. So I won't go into detail other than to provide you with absolute assurance that we've considered CMO's letter, and we've also looked at the where we need to stretch our staff, there's an escalation framework in place, and we've also looked at how we can mitigate where with new roles, new job descriptions, other support roles as well, to make sure that patients are actually safe in whatever environment that they're going to be cared for.
Thank you. Does the board have any questions? Thank you, Mandy. That was absolutely really comprehensive and gave us assurance of the incredible amount of work that's been done focusing on patient care. So thank you so much for that.
I think perhaps if I may, Chair, I need to say thank you to Lisa and her team, because without that level of support, we wouldn't have had all of those additional healthcare support workers brought into our services, and they have been absolutely critical in enabling us to put in place different ways of working and stretching the workforce. But also importantly, when we were talking about the family liaison roles earlier, and also the test, trace and protect activity that we're having to undertake, they are instrumental in enabling us to work in those ways and respond to demand.
Fantastic. And who would have thought at the beginning of this we were able to recruit so many local people to do all this? And it's a great testimony to the fleet of force and the agility, and to our population who come forward. So thank you, thanks Lisa as well. So the next item on the agenda is financial governance and value for money considerations 2.6. Hugh.
Chair, thank you, and I'd like to echo everyone else's thanks for the extraordinary efforts that have gone on over the last few months, and clearly that comes with some cost as well. So I just want to take you through the governance arrangements we've put in place, so that we're clear on the decision-making process, and I'll just highlight a few things. Firstly, I think it's important to recognise that the driver to the response to COVID has been the operational and clinical requirements of the organisation, not necessarily the financial constraints, recognising the feasibility of being able to undertake some of those in such a quick time frame. And you just alluded to the additional recruitment activity, and that's resulted in a cost for the Health Board which will equate to £10.8 million over a 6-month period. Not all of the staff that have been recruited have got contracts to go over that period, so the commitment is a little bit less, but the cost of 6 months would be 10.8, and that in itself is an extraordinary feat. And then there were a number of processes that were put in place to place orders, to equip the field hospitals, and to make sure that acute sites were able to respond. And just referencing the £5.8 million worth of orders were placed in order to equip the acute sites, £2.7 million worth of orders to equip the field hospitals. The process that we've followed on this hasn't been the normal governance process of seeking approval in advance of committing such a significant amount, but we have put in scrutiny through the gold command structure that we have in place. Finance Committee have scrutinised the expenditure in some detail, and I've taken a paper to the Audit Committee on going out to procurement without necessarily undertaking tenders for all of those procurement actions. I'm bringing it here today to retrospectively seek the board's approval for the expenditure and to make sure that we can now regularise this within the Health Board's governance structure, and just to provide the board with assurance that as of the 16th of April, after the initial significant work that was put in place, the board secretary and I wrote out to the organisation to say that the scheme of delegation is extant, it still exists, and it's important that we follow that in future decision making.
Thank you, Hugh. The board's content to approve the expenditure based on the scrutiny provided by the Finance Committee on the approval made by Gold Command. Yeah, thank you. Anna, sorry, come in.
Yes, sorry, Chair, just a quick question here, if I can, just to clarify whether the 10.8 million of additional staffing costs is a net figure after offsetting any vacancy underspends or reduced agency use, or is that does that not include any offsetting?
Thank you. This is the gross cost, so it doesn't include any offsetting, and it doesn't include any potential funding that may come in through Welsh Government for it.
Okay, thank you.
Thanks, Anna. The board approve the recommendations. Thank you. The next item on the agenda is the report of the Quality and Safety Experience Assurance Committee. Anna?
Thanks. Nothing to add to the reports as they stand, just to highlight that there are two reports this time round to reflect the increase in QSIAC meetings that were agreed as part of our COVID governance review. So the April report is full QSIAC, the May report is the COVID specific QSIAC, which members are also aware is supplemented further by a fortnightly meeting between myself and Mandy as the exec lead. Yeah, the reports as they stand, happy to take questions, and the only specific request to the board is to ratify the terms of reference that have already been approved via Chair's action, please.
Any questions? No. Well, thank you so much for ensuring that the QSIAC continues during this period, and thanks to Mandy as well. The board happy to ratify the terms of reference? Thank you. The next item on the agenda is the annual quality statement.
So I'd like to start by saying, and I know I keep saying this, but my team have done an amazing job on a number of key pieces of work that have enabled us to move forward. So Kathy and the team in the assurance department have worked wonders on this, I think. I think one of the things that I would like to say is that it has been quite challenging in terms of some of our routine engagement that we would normally undertake. So if Sharon, for example, had to move in a different direction, but there has been engagement, and of course that is down to COVID, not through any lack of us wanting to do that. The one thing I would say is that I believe that the report has strengthened further from last year's report, and in terms of its readability and user-friendly nature, giving us more detail about the improvements and strengths that we've gone on to from year to year. But also just to say that for next year, I'm expecting it to be even better with more narrative linked to the smiley faces that we've used. And some of that is down to staff meetings and further training to be able to help us do that and deliver it in a timely way.
Thank you, Mandy. Paul, you'd like to come in?
Yes, it's just to confirm that the AQS has also been the subject matter of an internal audit report which came before the audit committee yesterday, and it received that rare thing, a substantial assurance which is obviously good news. And they only had one issue which they wanted to highlight, and that was the need for it to be translated into Welsh, and I see that we've achieved that as well, so that's a really good piece of work.
Well done. Any other questions or comments? No, we've considered this on a number of occasions an excellent piece where it really is user friendly. So thank you. Next item on the agenda is the nurse staffing levels annual report 2019-20. Over to you again, Mandy.
Yeah, I won't go into too much detail, just other than to say that the attached template is a mandated template, so I wouldn't normally go into so much detail, but that's the reason why you have it there in significant level of detail. Just to mention as well, and I know it's something that Paul has raised on a number of occasions, is about how we can provide the narrative on a shift-by-shift basis as to the decision-making as to why a roster wouldn't necessarily be delivered on that particular shift in terms of staff work with versus what is calculated. And I received communication this morning to say that although we had originally thought that the system used the health and care monitoring system, which is the system used to capture all of the data and help us pull this report together, it was originally thought that that would slip in terms of its implementation due to COVID. It's likely now to go back to the timescales that we were hoping it would. I haven't had final confirmation of that, but I have agreed with Chris, who leads this work for me, that we will run with it locally if it is available from July. So that will then help and hopefully capture some of the detail that I know has been requested. The only other thing to flag is that you will see we did debate long and hard about whether the level of detail should be provided in this report, given that there's single numbers in the table that's attached on table 1 on page 3. But because it's, I don't know who the patients are, and I've got considerable insight into this, we ran with the numbers being significantly lower than we normally put into the public domain. That said, what the report and the analysis of the data has enabled us to do is identify that there's a further discussion that's required with one particular ward in one of our hospitals, and those discussions are taking place next week because the incidence and the staffing levels has flagged some concerns. So we will be taking that forward. So it's just to provide assurance that we do look at this and react when we see these issues being raised.
Thank you. Any questions? Thank you. The board's happy to note the report. Thanks, Mandy. And the next item on the agenda is the report of the People Planning and Performance Assurance Committee. And that's over to you, John.
Thank you, Chair. This report then is for the extraordinary meeting that was held on the 7th of May. Similar to Quasiac, PPAC has been stood down during the period of COVID, although you'll see from this report that it is now recommended that that be re-established from June onwards. The report essentially includes responses from members with regards to items concerning people, performance and planning, and that's noted in Appendix 1, and also questions that I had as chair, particularly from the previous meeting, which was on the 20th of February, and in fact the December meeting. So I guess the report is to give the board assurance that any outstanding matters from previous committees or questions from members have been addressed. I have got assurance from my meeting with the two pertinent execs, and this report provides assurance for that.
Many thanks, John. Any questions for John? Okay, and thank you. Again, it's really assuring that you've been taking this work forward for us and looking back and ensuring recommendations or action points are being delivered. In the governance paper, we do say to the board that this committee is going to be re-established in June, and obviously the board's happy to approve that. So thank you very much, John. So the next item on the agenda is the performance report. Okay, thank you.
Just to say, we're still in an environment with significantly curtailed performance reviews from Welsh Government, and that remains in place. So the report is not the normal wide-ranging report. I'm happy to take any specific questions on it, and offline if there are any reflections on further data that the board may want to see, then I'd be very happy to have that discussion.
And can I thank you for having this board, this paper in the public domain. I think we're only one of two boards in Wales that has a non-COVID performance report, and I think it's really important. And we made that commitment from the beginning of the outbreak. So over to questions. John?
Thank you, Chair. Again, I guess it's similar to the question that I raised earlier. Whilst we are expected as a board to be reporting on 5 key areas that are still mandatory, a lot of the other areas in terms of performance metrics have been, in the words of the Welsh Government, relaxed. However, if we look at the performance data, there are some concerns in terms of some of those, particularly in terms of stroke and perhaps the consequence of non-urgent outpatient appointment and surgical procedures not being performed, them having an impact on 36-week RTT, for example, diagnostic weight. So it is of concern. I will be expecting a report at PPAC with regards to how we are managing the consequential impact on performance of these targets, whether they are reportable ones or ones that have been relaxed, in order for me to be able to show a board.
Yeah, just on that, thank you, John. Yeah, of course, we do all share those concerns, particularly around our elective referral treatment targets, having had another strong performance last year, albeit up until the end of March when COVID hit us. I expect part of the Q2 and indeed the Q3 plan to start to look at how we can expand some of those services. But of course, it is partly because of the change in the risk equation for people, but also in terms of the capacity that the hospitals will have to be able to undertake elective care, given donning and doffing and other issues, and indeed people's willingness to go through what might be a period of self-isolation and other things before they come in for elective surgery. There's quite a lot for us to consider in all of that. So I absolutely share your worry. You know, we had, as a board, shown a really strong commitment to people not waiting unduly for their care. We've got to try and find a way back to that, but do it carefully and in a balanced way.
And if I could bring in Andrew as well to respond.
Yeah, it was just to provide some reassurance as well that in terms of some of those access targets that you referred to there, John, like RTT, follow-ups, diagnostics, the weekly watchtower meetings that monitor performance and monitor those waiting lists have continued throughout the COVID period, and patients are being reviewed clinically, and we are as far as we can keeping on top of that list and bringing people forward and expediting them as we need to. I think the challenge is going to be, as we outlined earlier, is just the complexity of bringing back online some of that work in an environment whereby then the ability to run at full capacity as we were before is going to be seriously mitigated. Obviously, one of the benefits we do have, and has sort of been negotiated at an All Wales level so far as part of the COVID response, is access to the Wernedale private facility as well in Howdar, and we, part of the Q2 plan, will be looking at how we use that to facilitate some of that re-establishment of elective work.
And John, thank you for ensuring that this is scrutinised in more depth and wider within your committee. Thank you.
Chair, can I also please, sorry to interject, make another comment, which is a positive consequence of COVID. It was pleasing to see, despite our interventions over many years to try and bring down our C. difficile rate and our E. coli rate and our Staph aureus, COVID has had the impact where actually we're now within target on each of them. So I think that's something we need to look at in a little bit more detail as to the positive consequential effects.
Yes, we and just to note really that the Infection Prevention Control Steering Group has recommenced, and actually we recommenced from last month because I was wanting to keep a very close handle on where we were. But you're quite right, John. We're hoping to see some positive benefits that hopefully will be maintained as we go forward.
Thank you. I'm going to bring Andrew in again and then Maynard.
Yeah, sorry, Chair, it was just a general point really. I just wanted to pick up that in terms of our non-COVID activity, one of the things we've seen since the start of the outbreak is a steady and consistent increase in our non-COVID admissions and activity through the unscheduled care system. And obviously, some of the, as colleagues have seen through the operating framework, some of the stipulations in there are around, in order for health boards to be able to respond to a potential further increase in COVID activity at some point in the year, it's recommended that we operate at an 80% occupancy level for our acute beds and 70% occupancy for our critical care capacity. That does put some constraints on how far we can reinstate services. But I wanted to flag that because in a couple of sites now we're approaching 70% occupancy. Operationally, we had made a call that once we started to get towards 70% occupancy, we would start to trigger our thinking around needing to mobilise maybe some of our additional field hospital capacity. I envisage that over the next couple of weeks, particularly in Carmarthenshire, as we start to bring back online some of our urgent elective work, together with the growth in non-COVID unscheduled care activity we've seen, that we may look to open some beds in possibly Carmarthenshire Leisure Centre. We originally had intended to run that as a pilot, but and as a test this operating procedure. But I think the reality of the operational position is that we'll be using that in earnest to help manage flow and to help maintain those occupancy levels at a safe level in line with the NHS Wales COVID annual operating framework. So I just wanted to flag that too.
Thank you. Simon and then Owen.
Thanks, Chair. Just a general question. I noticed that the military have been deployed helping WAST during the pandemic. I just wondered, perhaps a question to Steve, have we had any other interaction with the military in respect of Operation Rescript, which is the code name for the military operation, the deployment of military resources helping the NHS across the UK? Just wondered if we'd had any sort of interaction with them.
Yeah, we had quite a lot of interaction. Actually, probably Alison will be able to come in on how we're using some of the military support for our testing processes, and I think they've also been, they certainly helped out with the field hospital logistics as we were setting that up. But Alison, I don't know if you've got an update on how we've been using the military as part of our mobile testing.
Yep, so we have secured one military testing unit, mobile testing unit, which they're very happy to support us and be deployed in any way that we need. So they're currently supporting the care home testing programme, going out to the care homes alongside our infection prevention control and our long-term conditions team. So that's where their focus is at the moment. But we have the ability to step them up either as an additional lane, for example, in the showground facility, if we need to, but also for them to be working, we can set them up as almost as a pop-up testing unit across the 3 counties when we need to. So they have been very, very helpful, I have to say. Probably less used than at the moment than we would have anticipated, but they've been very good and will be very flexibly used going forward to support the testing programme.
And I think generally their support behind the scenes, Simon, has been fantastic. We're very grateful to have had them on board.
Thank you. Andrew?
Just on that, just on the specific point of input, I think you're right. We had a lot of input on the development of the field hospital logistics and the planning for those, and we've from a planning perspective around that, we've been lucky to have the input of Major Nolga during the period, who's been an invaluable resource and support to our thinking, and in particular getting us thinking now about how, when the moment's right, at the right moment, and we're not at that moment yet, but the fact that just as the planning to establish these field hospitals is critical, so will be the planning to hand them back at the end of the pandemic.
Thank you. Is there on the same point?
Just a couple of other things that Simon may be aware or not, but obviously as the Armed Forces champions, we've seen their flexibility as we go through different stages of this. So they started off with the command centre and were incredibly helpful there. But there's also, with what we heard at Team Wales last week, maybe 20% of our staff having PTSD, there may be a new opportunity to take expertise from different parts of the military going forward on how they help us with that. But I think their flexibility and willingness to adapt and bring different parts of their expertise has been really helpful, and we've taken advantage of that pretty early in all cases, really.
Thank you. I'm going to bring in Maynard and Owen. Maynard?
Thank you, Chair. It was just a quick question. In the non-COVID part of the performance report, where is improvement needed, there's a figure there for July to September on 2 MMR doses by the age of 5. I'm just wondering if you've got any more recent figures.
Ross?
Yes, I literally yesterday the report came out, so I haven't got that right at my fingertips, but Maynard, I could supply you with some up-to-date figures that literally came through for January to March yesterday, so I can do that offline with you if that's helpful.
That would be great. Thanks very much.
Thank you. Owen?
Thank you. Could I refer to the substance misuse paragraph at the bottom of page 2 on the S-bar, and the reference to exceptional demand on substance misuse services? I just wonder whether that was a pre-existing exceptional demand or as a consequence of the whole COVID situation, and if so, how is that being responded to? And as a sort of second part to that question, has there been an increase in attendances as a result of substance misuse in terms of A&E or ambulance call-outs, and anything in relation to the support available to people with substance misuse issues in the current circumstances?
Yeah, thanks. I'll ask Ross to come in on that if I may, but just to say we have had some data, and there is a mixed picture actually in terms of the data around substance misuse across the 3 counties. But Ross?
Yeah, so we've set up through the Area Planning Board a substance misuse COVID-19, like a contingency planning group. to try to bring all service providers together on a fortnightly basis to try to be as agile and flexible as we can to respond to demands on services and some of the challenges in the system. So there's been quite a lot of media coverage and anecdotal reports of increased use of alcohol during lockdown periods. So we embarked upon our media campaign advertising a single point of contact to enable individuals to ask for help, but also friends and families concerned about others to also make contact with services. We have seen a rise in the access and referrals through to our Tier 2 service, our third sector service, and the fortnightly meetings that we are undertaking to try to manage demands and challenges on these services. They're reporting through to that they're managing okay with provision. All providers across the Howell Our footprint are participating and engaging in this multi-agency type response for substance misuse, including our local authorities and our and enforcement officers through the police. And there are reports in terms of potential disturbances and issues to do with alcohol-related harm in particular, but they are all being supported and managed by existing services currently. I think time will tell in terms of whether we start to see then an increase in demand and referrals through to our Tier 3 service, which would indicate a much more severe and dependent type of harm, particularly in relation to alcohol. But of course, we are monitoring on a frequent basis through the support services that are still existing, such as our alcohol liaison nurse services and other structure and treatment services. So yes, it's very fluid, but we have got processes in place to really try to support all of those affected by substance misuse issues, either before COVID or during this pandemic, as best as we are able.
Thank you, Ros. I think Andrew wanted to come in.
Yeah, it was just to confirm really from what Ros was saying, in terms of our Tier 3 services, we've not seen a significant increase in referrals. There's been a bit of a drop in Ceredigion and Pembrokeshire, but Carmarthenshire has remained fairly consistent. As outlined earlier, a number of our services have been impacted by some of the shielding and risk assessment tools that we've had to go through with staff to protect them from the outbreak. And so there have been a couple of instances that I'm aware of where patients, because of that, haven't been able to access a couple of services that have come through to other parts of the secondary care system. But I've been reassured this week that we are providing a full, the service is there, it's just about access to it now.
And just on that, another team who are working probably around the clock of the communications team, and we are sending out regular communications around things like people's ability to sleep, people's use of alcohol, and how we can help to support them. You know, this is a worrying time for the whole population. We've seen a number of messages going out from the household.
Thank you. I just have one question on this report in relation to the numbers of patients who are medically fit for discharge. Has that reduced as a result of the initiatives or any other factor? And are we scrutinising what works if it has resulted in reduction?
I mean, there's been a significant change for us in the number of medically fit patients we've seen in the system. At the beginning of March, at the outset of the outbreak, we had 231 medically fit patients. As of yesterday, we had 90. There was a massive effort from all of our local authority partners and our community teams to discharge as many people as possible from our hospital beds to free up the acute capacity when we thought we were heading towards that really significant surge in demand. Those numbers have remained low. I think there is a sense that with some of the, I mean, we had the paper earlier on around social care, home resilience, and with some of the changes to the acute discharge pathway back to social care and some of the negative testing requirements for patients to be discharged, say, to a care home, we are starting to see a bit of an increase, but it's not yet at a point necessarily where it's giving us a a cause for concern, and that would also be where our additional surgery capacity that we put in place through our community hospitals and our field hospitals would start to play a part in easing some of that pressure. I don't know if Jill's got anything to sponsor.
No, I mean, we're certainly also looking at our community hospital numbers, and to be honest, they are almost at capacity in terms of the numbers that they've got. We have got some, as Andrew said, some additional capacity in new areas that we haven't opened up yet, such as Cleddau Ward, Tregaron, etc., coming online. But it's something that we know that we're going to have to watch, because as well with the testing, the sector isn't in the same place as it was, and we know that we will have reduced availability within our care homes. So it's certainly something that we need to look at. As Andrew said, we're looking at things around how we use our resources to best effect. Thank
you. I'd like the learning from enabling people who shouldn't be in hospital, because hospitals are not safe places to go forward, so we don't revert back to where we were before. Thanks everybody. Thank you for the performance update. And the board's happy to note that. And we're going to go on now to the reports of the Finance Committee. Michael?
Thank you, Chair. Nothing to add to the two reports that are in the pack, both of which focus on the last financial year. But I just wanted to just assure the board that the Finance Committee met this week, and we've turned our attention now to the unique challenges of managing the finances for 2021. And probably just to alert the board, even at this early stage, that achieving the financial targets will be a bit of a challenge.
Thank you, Michael. And I know there's a lot of uncertainty at the moment, isn't there? Anybody have any questions? It's all in the report. Thank you, Michael. And we're going to go then on to the financial report for month 1.
Chair, thank you. If I may, I'll just take you through some quick headlines and just outline some concerns I've got. Clearly, the initial financial plan was to deliver a deficit of 25 million after delivering savings of 34.2 million. And as Michael alluded to there, that will be a significant challenge for us. The month 1 position and the variance to break even is 6.3 million. Of that, 2.1 million is effectively the planned deficit, with 4.2 million being the variance against that. And that's basically splits between around 2.5 million, which is savings that haven't been delivered, and the balance being COVID costs offset by some underspends in areas like scheduled care. Clearly, there's a significant impact in terms of the in-year impact of COVID, and we're yet to have the finalisation of the resource envelope that we'll be working within, and the allocation that we'll get from Welsh Government as a response to that. Working through that with them at the moment. My concern is probably more around the underlying deficit and the impact of that, especially as we're not able to transact the savings that we planned this year, and the impact of that clearly will be an additional pressure on underlying deficit into the future. And linked to that is probably the pent-up demand that we've already spoken about, and the unmet demand potentially in the system, and the impact that recovering that will have going into the next financial year. So I think those are two things that are concerning as we think about the medium-term outlook.
Thank you. Any questions? We had a very detailed discussion at Finance Committee, and we do have an in-committee paper as well. It is a period of uncertainty, so thank you very much. Okay, the next item on the agenda is the report of the Health and Safety Assurance Committee. Judith?
Thank you, Chair. Yes, this was the first meeting of the newly established committee, obviously a reduced meeting. The main purpose of going ahead with the meeting was, if you look on page 1 under the Health and Safety Enforcement Action, we had a July deadline to respond to the HSE, so we needed to be sure that we were in a position to do that. If I take you then down to the massive concern, unfortunately the committee didn't receive enough information to be able to give the board full assurance that we were on track. However, as a result of that, we are going to have an additional meeting in June, where we should be able to give that assurance to the next board meeting, as the committee will receive the full information from the executive, the health and safety executive, the action plan, and where we are against the plan. We will also be considering at that special meeting the fire action update. Again, we didn't have enough detail to be able to give full assurance. I should say, to be fair, there's a number of people who are just coming to terms with the fact we have got this committee and work in a different way than reporting to a subcommittee. But we're very clear about the agenda required for the next meeting in June. I'll stop there and take any questions. Thank you.
Thank you, Judith. Any questions for Judith? Thank you, Judith, for everything you're doing in this, and Mandy. And we look forward to the next report. And now we're going to go into the committee update reports. The first one is a report which put together by Joe for ratification of some in-committee decisions.
So the two items that are on the bottom of the in-committee that the board need to approve in the public domain as these were taken into committee, mainly because one was detail of business cases which couldn't be shared at that point in time, and in terms of the charities plan, it had individuals' personal details in there as well.
Thank you, Joe. Are the board happy to ratify those decisions? Many thanks. Next is the charitable funds update report. Simon?
Members can see that this meeting, which was the last physical meeting that most of us have attended since the 17th of March, it was an extremely important meeting on account of the discussion and recommendation to board of the 3-year plan. We took the decision to recommend to a trustee meeting a significant increase in fundraising capacity, to institute a staff lottery, and to ensure that there's far greater focus on staff well-being, and it's going to be easier and less bureaucratic to draw that money down. The performance of charitable funds has been really strong, with increasing donations and legacies, significant expenditure at Aberyron and Ward 10 at Withybush, and following on from your comments, Chair, during the early part of the meeting, we've raised over £88,000 in respect to our COVID-19 How of Our Health Charities appeal, and that's been supported by over 4,000 people. So, and of course, there was a paper sent to myself as Chair and the Vice Chair on the 15th of May seeking endorsement under Chair's actions for plans to spend the money that we've had. We've had £105,000 from NHS charities together, and obviously we need to ensure that's spent in a timely manner. I'm not sure whether Sarah's got some additional information about our spending plans.
Thank you, Simon. Sarah, do you want to?
Okay, so thank you. So as Simon said, there couldn't have been better timing for that committee to be able to give us an ability to move fast and have some decision-making governance to move fast with the COVID situation. There are two pots of money, two types of money. The first, it is in the paper, but I think just overarchingly explaining this, we've received 2 COVID-19 grants from the NHS Charities Together grant funding, which is what Captain Tom is famous for. He's raised 120 million, or that pot has raised 120 million. We have had money, and we will have more money coming. The first tranche was £35,000 grant for us as a health board, and that was to immediately spend quickly on enhancing the well-being of staff, volunteers and patients that are impacted directly by COVID-19. So we got our first payment on the 8th of April, and it's been spent on, and we've set up our own charitable fund for that. By the 8th of May, which is what you've seen in your papers, we'd allocated 12,500. That basically, that whole 35 has already been allocated because of the overwhelming requests we've had from staff. So, and that's particularly, and there's sort of a new group that's emerged, and Jill's alluded to it, but those testing in care homes, so we've expanded it to those as well. So we've been getting out hydration, nutrition, wash kits, candles, patient welcome packs, supporting fridge for the A&E tents, a whole range of things like that that are about immediately making life more comfortable. So pretty much that 335 has been spent. Part of the reason it didn't go off the shelf as quickly is because the huge generosity of the general public meant but many of the things that the staff wanted were being provided by them. So I think there's a huge, you've already said your thanks, but that's why people thought, why haven't we spent more? It's because we had that overwhelming outpouring. Now we've got another 70,000, and that 70,000 we received on the 4th of May. And as we'd only, so what we did then is we put out a small grants scheme. We weren't sure if people would have time to apply. We've been delighted that over 220 staff areas, not staff, but staff areas, pretty much every staff area has put in a request for immediate support for up to £500. And the sorts of things, so we think that that 70,000 will be spent by next week on things like continuing things, staff restrooms and changing facilities, patient relative rooms, critical care patient hydration, creation of new staff rest areas, a whole range of things. And there is a meeting of the 3 execs who need to sign that off through the existing ordinance on Tuesday to do that. So we have a list of green items that are absolutely fine, and then some items that we want to make sure we check on, because what we do need to make sure is it's fair and equitable, and that all staff who need things can get them. So we're confident that we can do that. Then there's another chunk of money, which is our own Help Bar COVID-19 fundraising appeal has, as of yesterday, raised £88,800 because of the generosity of our population. So a huge thank you to them. Of which the gentleman you mentioned, he's raised half of that himself. So that's great. So basically, some of that will probably be able to fund some of the staff requests we've had, the 220 staff groups. And then we may need to appeal for extra things and extra funding as well. But Lisa may want to carry on from me, but basically we now want to really find out what staff want, and that's more Lisa's leadership, but an element of what staff might want is going to be able to be funded through the charitable funds, the COVID-19 fund, but also some of the existing funds that we've got. So that's our next stage. There are 2 more tranches of grant funding coming down from the national charity, and they will be, we don't know how much or when, but they will be focused very specifically. The first tranche under stage 2 will be strategic integrated community and social care pathways. So that's something that Jill and Andrew will very much have a part to play in, what's needed there. And then the last stage 3 will be COVID-19 recovery and post-pandemic. Staff and population, so we don't know when or how much that will be, but if they've raised 120 million UK-wide, it will be a sizable sum of money. So what we would plan to do is, when Lisa's team have met, and many people across the organisation will be part of that, is take that to either the Charitable Funds Committee for sign-off, or to the corporate trustee if it's over 100,000. So we plan to come back in that way. So I don't know if Lisa, if you want to ask Lisa to carry on for the next bit.
Thanks, Sarah. Lisa?
Okay, so I've been having conversations with Christine Davis, who is our Assistant Director for Organisational Development, and part of the workforce strategy that we had was that we wanted to engage with our workforce to find out what would make this the place that people really want to work. How could we improve working lives? How could we improve work-life balance? What things really make a difference to people? So what we're going to do with our OD team is begin a mass staff engagement process whereby we get out to every corner of our organisation to start to ask people what would be really valuable to them, what would they like to see in place. We want to listen to everybody's voice, so we're going to go out to the whole diverse workforce, because people will want different things in different places. And some of the things that you've seen in that paper can quite specifically link to hospitals. And we've got a massive workforce that aren't hospital based. Therefore, we really need to understand what people want. So the group is going to be established by Christine. The OD team are going to work with Sarah's engagement team to use our new engagement tool so that we can capture all of the data. And what we will then start to bring forward is what people really want to see. And the outcome of that then will be, what can we then use charity money for? What can we not use charity money for? And therefore, what plans do we need to look at our finance colleagues to see if we can fund within the organisation, and what can we look outside of the organisation for support for? So it's to bring together what people want and then understand where do we get the funding from to be able to do that.
Thank you. Any questions from board? Judith, Mike.
Thank you, Chair. Thank you. Yeah, thank you for the paper. I think it's really welcome to see, and it's so important that we're very open about where the money is going, because you know, so much being raised through so many avenues, and really huge thank you to our local communities for doing that. I do welcome Lisa's comments about the fact that the list did feel very hospital focused, so I really welcome the work she's talked about. My question is that I've had some contacts from people I know who are keen to see if they can help from using the industries or businesses they're in for our staff. So who am I best to speak to, or to direct those people to have that conversation with?
Through the COVID inquiries contact in the first instance, because then it will get sent out to the relevant executives so that we can pick those issues up. That's where we've directed all other offers of help, and it just keeps it centralised and logged and managed, would be my suggestion.
That's what we've done with all the others, Mandy, for many businesses to explore that.
Thank you, Judith. Mike.
Thank you, Chair. Thank you for the paper. Really helpful to see the numbers involved, and I think, as you've alluded to, this is not just about the money, is it? It's a reflection of the way that the public and organisations and companies locally have wanted to recognise the way that the NHS staff have stepped up and continue to step up in the last couple of months. The only thing I can't see, Sarah, just reading the paper quickly, is in addition to the money that we've received, I'm aware that you raised the opportunity for people to support by way of giving practical gifts. I think there was an Amazon wish list scheme, for example, and I just wanted to acknowledge that publicly, that people have also been supporting through that, and I can't see that in the paper.
Can I just say that was in the patient experience report with a clip actually from Alice, who's one of our apprentices, who's talking about the gifts that they've and the generosity that they've received. So we didn't cover it in both papers.
Thank you. Sarah, so perhaps if I can say, so the paper that was there was very specifically about the grant money that we'd received from NHS charities together. I think it's been mooted that we should have another report, because things are moving fast, to update the board more formally on how the money's been spent, the next tranche. But all the things that we've done. So yeah, the Amazon wish list has been great. That's the sort of thing that people have donated. I think it would be fair to say none of us obviously expected COVID, and we were taken aback by the generosity and the overwhelming nature of offers of help. So it did take us a while sometimes to get back to people, and apologies if we didn't get back to people quickly, but actually offers of help aren't actually the charity's responsibility. That's something as an organisation we haven't really had before. So I think it gives us a new opportunity to think about how we work with businesses, the public and others going forward in a way that's more of a partnership. That's a new area. There isn't an executive responsibility for that. It's donations were coming in everywhere on all sorts of things. So it's a huge thank you, but sort of bear with us as we sort of get that into our normal processes with process around it. But it's just been an overwhelmingly positive response.
Just on that specific point, it's going to be one of the areas of consideration for the transformation steering group about how do we move that forward, because it has been remarkable.
Absolutely. Well, again, I'd just like to reiterate a massive thank you to everybody. Incredible generosity, and I think we'll chat with Simon and Joe and Sarah outside about the governance, because putting all those monies together, it's a huge sum, and whether it should come to the corporate trustee after charitable funds or the other way around, but we can do that. But thank you, everybody. And so the next item on the report is the IC in committee, board. We've done that one, sorry. Statutory partnership. Anna, did you want to come in?
I can ask Sarah offline, it's no problem.
That's grand. Okay, thank you. So the next item is the statutory partnerships update. Sarah, it's you again.
Just very quickly, there's two elements to this. Public service boards, which have met virtually in a method like this using Teams, and have basically just been sharing what they've been doing. But I think probably the strapline for public services boards is through the local resilience forum, which Ros is part of. Partnerships were already on a strong footing, but we kind of stood on those strong foundations and maximised those. So partners have worked together in a way that we've never seen before. On the regional partnership board, you'll see some more formal recommendations to note, but actually it changed and morphed into a COVID-19 focused integrated executive group, changed into that, reporting into the RPB. And I think actually it's a tribute to Jill and many others that just groundbreaking work was done through this partnership. That again, sometimes partnerships have always got tensions in them because they're not easy. Everybody around that table worked through those tensions and through the difficulties on PPE, on care home pathways, on testing, on a whole range of things, Lisa on workforce, and resolved issues and found solutions. So I think that would be the strapline for the RPB. All of the, there is some detail in the paper, and I think it's come through other committees and finance committee, but the ICF monies was diverted to support the COVID-19 work, and that's there for you to note as well. But we are now starting to have those conversations about how to, like the transformation steering group, how to not lose some of the benefits of this and how to accelerate the good partnership working. No, probably otherwise the recommendations are there for you to see.
Thank you, Sarah. Any questions?
No. Just make a point. Please, Chair. I think it's important in terms of when we're talking about diverting Transformation Fund and ICF, the way our plans have actually been established in terms of Transformation Fund in particular has actually seen an escalation of almost of the things that we wanted to do, but for the case of COVID. So we've actually moved forward significantly in terms of transforming our services, albeit the mechanism has, as I say, has been around COVID. So using Delta wellbeing, using our third sector for community connectors, enhancing a whole range of things were part of our plan. So we've almost not lost ground in terms of that journey, and therefore the resource has been used appropriately and effectively.
Thank you, Jill. Thank you very much, and the board are happy to accept the recommendation and agree the continuation of the Health and Social Care Leadership Group. Many thanks. The next item on the agenda is the board work programme, which will change. And then the next item on the agenda is the ethics. Phil, do you want to say anything about this?
Sorry, just coming off mute. Only to say that that is the national guidance and some really useful information, I think, for board members, which we're using to help guide our discussions at the ethics panel, which of course you chair. And we found it very useful. We've already started helping advise Gold Command on strategic ethical issues, and we're just about to submit some guidance to clinicians around critical care usage, bed usage. Thank you, Chair.
Phil and I are both open to any questions offline, and we can share as many documents as people wish on the ethics panel and it's the broader representative panel. We're 10 minutes over the first part of our open board meeting, but I just want to say a huge thank you. It's been a massive agenda, and it shows as much as possible in paper of what's been happening across the organisation in the last 2.5 months. An incredible achievement. There aren't words for it, and I thank you to everyone. And as we've mentioned before, and Steve mentioned about the teams going into care homes, there's lots of people doing things that aren't seen. So we are a whole health board. It's not just, you know, it's everybody. So I just want to end by saying thank you to the governance team and the IT teams for all the work they've done behind the scenes to get this virtual board working, all the committees working, and servicing the goal command and structure. So we really appreciate all what you've done. I know we're running around and we don't get to say it, but thank you very much. And I'm really proud that we're the only board that are able to transmit to our community at this time when public can't come into our meetings. So many thanks everybody. There's a 10-minute break and then we'll have the in-committee board. Marianne.
Sorry, can you all hang up, and if you are staying for the in-committee board, come in on the other link. So you need to join the teams on the next link, if that's okay.
And that's within 10 minutes. Diolch.